Thank you for this invitation. It's a pleasure to be here. You have nice spring here. We have tons of snow in Finland, so it's very different. So our next topic is Dermatitis herpetiformis, skin manifestation of celiac disease. I'm also very happy to talk about Dermatitis herpetiformis because this is a topic that's rarely discussed in conferences. It's usually forgotten, so I'm happy that you were interested in this issue. First of all, here you can see the major milestones in the history of Dermatitis herpetiformis. As you can see, the clinical picture was first described already in 1884 by Louis During. So that was actually 4 years earlier that the clinical picture of celiac disease was described by Samuel G. However, the exact diagnosis was not possible before year 1969 because that was when van der Meer first showed the immunofluorescence findings typical for DH. And a couple of years before that, Marx showed that the majority of Dermatitis herpetiformis patients have enteropathy, which is usually asymptomatic. And also in the late 1960s, Fry from UK published an article stating that gluten-free diet is the treatment for Dermatitis herpetiformis. So we have actually known since late 1960s or early 1970s that Dermatitis herpetiformis is an extraintestinal manifestation of celiac disease. We have known since then that there is similar enteropathy in both, and also that gluten is the environmental factor behind both conditions. Further, we have later learned that there is similar genetic background behind celiac disease and DH. Both have a strong association with HLDQ2 or DQ8 in chromosome 6, and also since the same genes predispose to DH and celiac disease, we often see these two conditions in the same families or even in identical twins. Further, we have later learned that there is similar autoantibody response against transglutaminase 2 in DH and celiac disease. However, it must be kept in mind that even though Dermatitis herpetiformis is one phenotype of celiac disease, it's not just ordinary celiac disease, since it's also a chronic itching and blistering skin disorder. So how common is Dermatitis herpetiformis? Previous knowledge about the prevalence of DH has varied quite a bit, but luckily there are two little bit more recent reports, one from Finland and one from UK. And in our study, which was published in 2011, we published the highest prevalence of DH so far, 75 to 100,000, and that meant that in Finland, approximately 13% of celiac disease patients had Dermatitis herpetiformis. In the UK study by West et al., which was published a couple of years after our study, it was shown that the similar percentage of celiac disease patients had Dermatitis herpetiformis as in Finland, but the prevalence was almost 3 times lower in UK. Also, when the incidence of DH was investigated in these two studies, the incidence in UK was almost 3 times lower than in Finland. But as you can see, the study periods are not identical in these two studies. In our study, we showed that the incidence of Dermatitis herpetiformis has declined both in females and in males, and the decline happened especially between years 1980 and 1990. We also showed that the highest incidence of DH was in females and in males between 50 and 59 years of age. Also in the UK study, the incidence of DH was shown to decline, and the highest incidence was in patients between 50 and 69 years. So it's very interesting that the incidence of DH seems to decrease. We know at the same time the incidence of celiac disease is increasing, like we saw in the morning. Our hypothesis in Finland has been for long that Dermatitis herpetiformis is a late manifestation of undetected and untreated celiac disease. And since we know that nowadays more celiac cases are found, they are treated earlier and better, we think it's only logical that less DH develops nowadays. Also, what's different between celiac disease and Dermatitis herpetiformis is that Dermatitis herpetiformis is almost as common among males and in females, and you know that celiac disease is much more common among females. Also, DH is much more rare among children. In the UK study, 8% of patients were diagnosed under the age of 17, and in the Finnish study, less than 4% were diagnosed under the age of 16. But with that said, DH can be diagnosed at any age. Our youngest patient has been 3 and oldest has been over 80. But the mean diagnostic age in Finland in our almost 500 DH patients between years 1970 and 2009 was 43 in all patients. But as you can see, the diagnostic age increased from 1970s. It actually increased by 13 years, so that's a big increase. We know that similar increase in the diagnostic age has also happened in celiac disease. We don't know the exact reason for this. It might be something in the diet, but we don't know yet. So the clinical presentation of Dermatitis herpetiformis is an itching, blistering rash, and the most typical sites of DH involvement are elbows, knees, and buttocks. Of course, other skin areas can also be involved, but even then, almost always the typical sites are also involved. Sometimes we see facial lesions, but rarely lesions in the mouth. There's of course fluctuation in the severity of the disease in the same individual, and between individuals there are differences in the severity of the disease, but almost always the itching is quite severe, that one has to scratch the skin and the blisters are eroded quite easily. So what we usually see when we meet DH patients is only crusts and excoriations in typical DH rash locations. This is quite typical what we see when we meet DH patients. And if we see the blisters, they are quite clear. Here you can see one blister in the elbow, which is typical site of DH involvement, and then a little bit more atypical sites on the neck, groin, and also in the face. And sometimes patients come and just show us this facial lesion. And if you only look at this face, it would be quite easy to mistake this for example, herpes simplex infection. But in these cases, if they also have itch, you have to check the other sites also, because these patients also have lesions in the elbows and knees almost always. The clinical picture is not enough for the diagnosis. We have to confirm the diagnosis by taking skin biopsy. Skin biopsy is taken from healthy skin next to the rash, and it's studied with direct immunofluorescence. And pathognomonic finding for DH is this granular IgA in papillary dermis, and this was a finding that was described already in 1969 by van der Meer, so quite a long time ago. But it was not until 2002 when Sardi first showed that this IgA is directed against epidermal transglutaminase, transglutaminase 3. Since then, transglutaminase 3 has been considered the autoantigen of Dermatitis herpetiformis, while in celiac disease it's transglutaminase 2. Small bowel biopsies are not necessary for DH diagnosis, but at least in Finland we still perform gastroscopies and small bowel biopsies are taken in majority of patients. This is probably going to change in the near future because the diagnostic criteria for celiac disease and Dermatitis herpetiformis are under revision in Finland at the moment. But if small bowel biopsies are taken, the majority of DH patients have some degree of villus shortening in the mucosa or even total villus atrophy. However, 1/4 have normal villi in the small bowel mucosa, but even these patients have inflammation in the small bowel mucosa. Regardless of these small bowel mucosal changes, obvious gastrointestinal symptoms are quite rare in DH. And if we look at the inflammation in the small bowel mucosa more carefully, quite typical for DH is that the density of intraepithelial gamma delta cells is increased in Dermatitis herpetiformis, similarly as in celiac disease. However, investigation of these cells requires frozen small bowel biopsies, which is a special method, and it's not available in every center performing gastroscopies. At least in Finland it's not. Interesting is that the severity of small bowel mucosal lesion has become milder in Dermatitis herpetiformis during the last decades. Here you can see a figure from our quite recent study where we investigated the severity of small bowel mucosal lesion in Dermatitis herpetiformis in 3 different time periods. And as you can see, the percentage of subtotal or severe villus atrophy became less common, and milder villus atrophy and normal villus structures became more common. So the degree of mucosal lesion has become milder in Dermatitis herpetiformis, similarly as in celiac disease. And we have also shown quite recently that in Finland the diagnostic delay of Dermatitis herpetiformis has decreased from 12 months to 8 months since 1970s. So DH cases are nowadays diagnosed earlier, so that's probably the reason why the small bowel mucosal lesion is less severe. However, we have also shown that the severity of DH rash has not changed in Finland since 1970s. DH patients are known to have IgA autoantibodies to tissue transglutaminase in the serum, similarly as celiac disease patients, and what we use in clinical practice are endomucil and transglutaminase 2 antibodies. And these two celiac autoantibodies are known to be very reliable in celiac disease, but the sensitivity is a little bit lower in Dermatitis herpetiformis. There are some studies showing that serum celiac autoantibody positivity in DH correlates with a degree of small bowel mucosal damage, like we did in our previous study. Here you can see that transglutaminase 2 antibody titers are higher in those DH patients who had severe villus atrophy compared to those who had partial villus atrophy or even normal small bowel mucosa. And as you remember, I said that 1/4 of Dermatitis herpetiformis patients have normal small bowel mucosa at the time of the diagnosis, and it's quite possible that these patients have negative celiac autoantibodies in the serum. So negative celiac autoantibodies in the serum do not exclude Dermatitis herpetiformis. There are quite old reports showing that these antibodies are produced in the small bowel mucosa. We heard in the morning that there are new theories also, but however, these antibodies can be investigated directly from small bowel mucosa. Ilma Korponen-Saabo showed in 2004 that these TG2-targeted IgA deposits can be investigated from frozen small bowel mucosal samples. And these deposits are very sensitive and specific for celiac disease. We investigated these deposits also in Dermatitis herpetiformis, and the majority of patients had these deposits at the time of the diagnosis, but as you can see, only 80%. In celiac disease it's almost 100%, so a little bit lower percentage. Also in Dermatitis herpetiformis it was shown that the presence of these antibody deposits correlated with a degree of small bowel mucosal damage, and they were gluten dependent. I want to mention shortly transglutaminase 3 antibodies in the serum. These are something that are not in clinical practice, but very interesting. I told you that the skin response in Dermatitis herpetiformis is directed against transglutaminase 3, but the antibodies that we measure from serum are transglutaminase 2 antibodies. However, we know that there are often transglutaminase 3 antibodies in the serum of Dermatitis herpetiformis patients, but we don't know what's the role of these antibodies. They are thought to be quite specific for Dermatitis herpetiformis, but surprisingly, sometimes we see these antibodies also in the serum of celiac disease patients without any skin symptoms. And we don't know what's the role of these antibodies. Somebody might think that they are a marker of future possible development of DH, but we don't know yet. So the treatment of Dermatitis herpetiformis, of course, is gluten-free diet treatment, and in Finland, almost all DH patients follow gluten-free diet treatment. And as you can see, majority of patients use oats. However, we know that the skin symptoms disappear quite slowly along with gluten-free diet treatment. It can take months or sometimes even years for the skin symptoms to disappear, and therefore patients with severe symptoms need additional treatment. Luckily, Dapsone is a treatment that causes rapid relief of the rash. It usually relieves the rash within a couple of days. And in Finland, 65% of DH patients start Dapsone. We start with a dosage of 50 milligrams, so that's quite small. And after a couple of weeks, we go down to 25 milligrams. So quite low dosages are enough for our patients. And then the medication is discontinued within a couple of years. However, we know that there are some patients who are never able to stop dapsone treatment. You have heard about refractory celiac disease. It's a condition that often has a poor prognosis, but refractory DH is a condition that's quite unknown. To my knowledge, there's only this one study about refractory DH from Finland. In this study, we went through all our alive DH patients, a little bit more than 400, and found 7 patients who fulfilled our criteria for refractory DH. So these patients had been on a strict gluten-free diet treatment a median of 16 years, so a very long time, but the skin was still active and they needed dapsone treatment. They had more IgA in the skin compared to DH controls, but small bowel mucosa was normal in all undergoing gastroscopy, and they didn't suffer from abdominal symptoms more than controls. So this is only one report, of course, but it seems that refractory DH is quite rare, and it's different from refractory celiac disease. None of those patients had lymphoma or any malignancies. But of course, we need more research on this issue. DH patients are known to have increased risk for autoimmune diseases, similarly as celiac disease patients, and also in most conducted studies, the risk for lymphoma is increased in Dermatitis herpetiformis, but luckily gluten-free diet treatment reduces the risk for lymphoma. Bone complications are very known complications of celiac disease. There's lower bone mineral density and also increased risk of fractures, but bone complications in DH are not well studied. To my knowledge, there are 2 studies showing that bone mineral density is a little bit lower in Dermatitis herpetiformis compared to controls, and in 2 studies, the bone mineral density was normal. There's only one fracture study, and that's from UK by Lewis et al. And in that study, the fracture risk was not increased in Dermatitis herpetiformis. But of course, again, we need more research on this issue. Mortality is very interesting, of course. We know that mortality in celiac disease is increased, but surprisingly, there are some studies that show that mortality in DH is actually lower than in the population. In our recent study, we showed that the all-cause mortality and also mortality due to cerebrovascular diseases was lower in DH compared to population. We also performed a questionnaire study, and in that questionnaire study it was shown that our DH patients smoked less than population, and they also used less cholesterol medication, so they probably had lower cholesterol values. So that offers one explanation why DH patients in Finland die a little bit less than they are supposed to, but we are researching this further now. And lastly, we move on to the burden of DH. And of course, this patient perspective is very important when we talk about chronic diseases. We know that lowered quality of life is associated with many chronic itching skin diseases. And we also know that quality of life is lower in untreated celiac disease. However, in celiac disease, the quality of life increases along with gluten-free diet treatment, but it doesn't necessarily reach the level of healthy controls. Very little is known about quality of life in Dermatitis herpetiformis. Our PhD student Camilla Pasternak has performed 2 questionnaire studies about quality of life in DH, and in Camilla's studies, these were questionnaire studies. There were 50 and 75 patients in these studies, and also celiac disease controls. Quality of life was shown to be lower in untreated Dermatitis herpetiformis, and it was especially low in those DH patients who had abdominal symptoms in addition to skin symptoms compared to those who only had skin symptoms. However, luckily after 1 year of gluten-free diet treatment and also in long-term treated DH, quality of life was similar to controls, and it was better than in celiac disease. So based on these studies that I have shown you today and several other studies, I think we can conclude that all in all, long-term prognosis of DH patients following gluten-free diet treatment is quite excellent. Thank you.
Great. So probably got a couple of minutes if you want to ask questions.
Should I speak into the mic? That was a really excellent talk. I learned a huge amount. Can you tell me what the entity is that communicates between the gut and the skin? Is it translocated gliadin peptides? Is it autoreactive T cells? Is it gamma delta T cells? Is it immunoglobulins?
That's quite a big question, and we have to figure this out. And what's the whole pathogenesis behind Dermatitis herpetiformis? We thought it comes from guts, but we don't know. There are new theories now.
Non-gut theories.
Yeah, we'll see.
Hello, Tony Cartwright. Dapsone is really quite a nasty drug, causes blood dyscrasia, so patients have to be monitored. Are there any other drug treatments you use other than Dapsone?
Well, actually, we rarely get any problems with Dapsone because the dosages that we use are quite low. The problems come if the dosage is 100 or even higher than that. 50 milligrams is a low dose, and we rarely get any complications. Maybe sometimes a little bit anemia, but nothing severe. And almost all our patients they use Dapsone. I think there's only one patient that uses sulfasalazine.